Hello and welcome. Thank you so much for joining us. My name is Julia Jones. I am a medical science liaison with Castle Biosciences. I'm very pleased to introduce to you Dr. Matthew Goldberg, who has served as our medical director since August of 2020. Prior to joining Castle, he was an assistant professor in dermatology and pathology at the Icahn School of Medicine at Mount Sinai in New York, and he still retains his affiliation as an assistant clinical professor of dermatology there. Before joining the Mount Sinai dermatology faculty, Dr. Goldberg directed dermatopathology education for the MedStar Georgetown Washington Hospital Center Dermatology Residency Program. He has a background in translational melanoma research and received the Dermatology Foundation Dermatopathology Research Career Development Award for his research in the field of melanoma epigenetics. He graduated summa cum laude from Princeton and received his medical degree from the Icahn School of Medicine at Mount Sinai, where he graduated with distinction in research. Dr. Goldberg completed his dermatology residency at the University of California, San Francisco, and completed a dermatopathology fellowship at the University of Texas Southwestern. He's board certified in dermatology and in dermatopathology. Welcome, Dr. Goldberg. I will turn it over to you now.
Thank you, Julia. So today, thank you all for joining. We're going to be discussing two tests here from Castle Biosciences, the myPath melanoma assay and DecisionDx melanoma, to really describe the role of gene expression profiling for the benefit of patients seen by dermatologists and dermatopathologists alike. Just for the agenda here, we're going to be going through a discussion about 45 minutes talking about the patient journey and from the diagnosis of pigmented lesions that are suspicious in the dermatology clinic onto informing management decisions for patients with invasive cutaneous melanoma. And then we'll have time for questions and answers at the conclusion of the discussion. So just as background, Castle Biosciences has developed a suite of molecular tests that are designed to inform important decisions in the patient journeys across a range of conditions focused on dermatology, with tests directed at cutaneous melanoma that we'll focus on today, both diagnostic adjuncts as well as prognostic assays that we'll discuss, the myPath test and DecisionDx melanoma, as well as tests that focus on squamous cell carcinoma with one or more risk factors, uveal melanoma for melanoma that affects the eye, and recently with an acquisition of TissueCypher assay for patients diagnosed with Barrett's esophagus for risk stratification for esophageal carcinoma. Essentially, Castle Biosciences is committed to using gene expression profiling and other molecular approaches to inform important decisions in patient journeys across a range of conditions. So, focusing here on the treatment of melanoma, we want to start with a patient journey of how patients begin their interactions with the medical community. Essentially, patients are seen by frontline clinicians, dermatologists, or other healthcare providers that are performing skin exams and evaluating lesions based on their concern that they may be malignant melanoma. When a concern threshold has been reached, a biopsy is performed, and that diagnostic biopsy is sent to pathology for review by pathologists and dermatopathologists. A definitive diagnosis of melanoma can be established through this process, and multiple decisions come after the diagnosis of melanoma has been made, which include multiple follow-up considerations about the need for additional staging procedures like sentinel lymph node biopsy and other follow-up discussions afterwards. And so we'll really be tracking this through our discussion today, from diagnostic adjuncts to improvement of prognosis as well. The first point that we'll focus on is on the myPath melanoma assay, which can offer increased clarity for dermatopathologists who are interpreting skin biopsies and dermatologists establishing treatment plans for difficult to diagnose melanocytic lesions. DecisionDx melanoma, prognostic gene expression profile test, informs management decisions that follow a definitive diagnosis of melanoma, will be the second focus of the conversation today. So, on the first part of the patient experience, there's been a huge amount of advancement in the field of clinical dermatology that speaks to a high level of concern that clinicians have about identifying concerning lesions appropriate for biopsy. These types of modalities include serial photography or total body photography, dermatoscopes to perform dermoscopy on lesions, reflectance confocal microscopy, and increasingly AI tools that are used for the visual analysis of lesions for patients who come into the dermatology clinic to determine whether or not a biopsy is appropriate. And this has led to an increase in diagnosis of melanoma, which is been one of the significant growth of melanoma diagnoses in the past decades, where it's a greater burden on the healthcare system as more patients are diagnosed with invasive cutaneous melanoma. You see here on the right that it's the fifth most common cancer type here in the United States, as tracked by the SEER registries. And what happens for patients who obtain biopsies is that there are clear treatment pathways that follow definitive diagnoses. So of all of the biopsies that come in, dermatopathologists can identify whether a lesion is benign or malignant through histopathological review. And seen here on the top row, when you have a definitive diagnosis of a benign lesion, the treatment that follows is no additional surgical treatment is needed, and the patient can return to routine follow-up, essentially gaining reassurance from their clinician that the lesion is not harmful to them. On the bottom row here, if a definitive diagnosis of melanoma is established, definitive surgical treatment in the form of a wide local excision takes place, and then the subsequent management decisions that follow from that step, such as sentinel lymph node biopsy, cadence of follow-up, imaging, etc., all follow based on the tumor characteristics and potentially gene expression profiling of the tumor. However, the story is not as simple as this, which I'll explain here in just a moment. So again, we estimate that there are about 2 million biopsies that are performed every year by dermatology clinicians for pigmented lesions of concern. And the overwhelming majority of these lesions are in fact benign, seen here with the figures here in gray. In addition, the malignant melanoma diagnoses can be established from this set of concerning pigmented lesions, and those are seen here in red. But there's this group in yellow, these patients with ambiguous histopathology, diagnoses that are difficult to accurately classify as benign or malignant. They we estimate to be about 15% of the total biopsies taken for suspicious pigmented lesions, around 300,000 cases per year by our estimates. And this is the focus, and really the unmet clinical need here is addressing this diagnostic uncertainty. There's extensive literature about the impact of diagnostic uncertainty in the management of patients who have these ambiguous melanocytic neoplasms, and it's not a trivial subset of these lesions here. Over many years, there's been multiple studies here documenting the extent of this ambiguity, and it actually can be impactful for things that can impact the staging criteria itself. So differences in interpretation, not only about whether a lesion is benign or malignant, but also including whether or not a lesion is ulcerated, the extent of the breast low thickness, etc. Some of this diagnostic ambiguity can really impact patient management decisions, as small changes in the histopathology analysis can lead to differences in how patients are managed. And so what happens in practice is that lesions that are biopsied, actually a significant portion, about 15% again, are in this orange box of uncertain malignant potential. And what happens here is that clinicians receiving reports with ambiguous diagnoses or diagnoses that connote an uncertain malignant potential will often be treated to the worst case scenario in the differential diagnosis. And essentially what this means is that lesions that may not be malignant, that may not benefit from having a re-excision, will obtain a re-excision of a lesion that really offers patients no benefit for their outcomes and survival. So this could lead to significant overtreatment, where lesions that, again, could be considered to be melanoma based on diagnostic ambiguity, but are actually benign. This can lead to significant overtreatment and cost burden to the healthcare system. And so a definitive diagnosis really informs management decisions that follows the histopathologic interpretation of these melanocytic neoplasms. And to get to a definitive diagnosis, dermatopathologists have multiple tools at their fingertips. Routine histology with multiple levels, under analysis using a light microscope, immunohistochemical stains can be performed. This is all part of the routine management that derm paths use on a regular basis. There's also ancillary testing options that are commonly used to inform their diagnosis in more ambiguous or difficult to diagnose cases. And these include techniques like getting a second opinion or obtaining other molecular tests like FISH or array-CGH. And gene expression profiling is one of the tools that dermatopathologists can use to go from uncertainty to certainty in their diagnostic evaluations of skin lesions. And that really provides the background for the unmet clinical need of where the myPath melanoma test fits in. Launched in 2014 with a proprietary CPT code and has been covered by Medicare since 2019. Over the series of next slides, I'll go through the peer-reviewed literature that describes the clinical validity and utility of the myPath assay. And again, many clinicians have used and ordered this test with approximately 35,000 clinical orders to date across multiple academic centers across the country, including NCCN and NCI facilities. So what is the myPath melanoma assay? Fundamentally, as discussed, it was developed to inform optimal decision-making when the histopathologic evaluation of a lesion leads to an ambiguous diagnosis or a diagnosis with uncertain malignant potential. And so the test is a gene expression profile from the formalin-fixed paraffin-embedded sample of the biopsy itself, where RT-PCR is performed using a locked algorithm to classify lesions as one of three gene expression profile results. Gene expression profile of a benign, suggestive of a benign neoplasm, gene expression profile that cannot exclude a malignancy, that intermediate zone, and a malignant gene expression profile that's suggestive of a malignant neoplasm. That is the output of the myPath melanoma assay. There's 9 publications in the peer-reviewed literature supporting the use of myPath melanoma for ambiguous melanocytic lesions, and has a high level of accuracy when compared to 2 types of reference standards. In the literature, those 2 reference standards are, one, the histopathologic assessment of experts. So when you have a group of experts who ascribe a benign or malignant diagnosis to a set of lesions, the test has a very high level of sensitivity and specificity to correctly identify lesions that get the histopathologic diagnosis of a benign lesion with a benign gene expression profile score, and similarly identify lesions that have a consensus diagnosis of malignant melanoma as a malignant gene expression profile score, again leading to sensitivities of 90 to 92% and a specificity of 91 to 93% across multiple studies with over 1,000 cases. On the right-hand side of this slide, the performance of the test has also been compared to patients with known outcomes. So independent of what the pathologists describe the lesion as being benign or malignant, this is a comparison to the myPath melanoma's ability to identify lesions that metastasized as obtaining a malignant gene expression score and lesions that did not metastasize as obtaining a benign gene expression score. And here the sensitivity is 94 to 97% and 89 to 96% specificity across 2 studies compared to outcomes. So either way, the accuracy is evaluated by histopathologic consensus or actual patient outcomes. The test has a high level of sensitivity and specificity to inform management decisions. This test has been performed on over 35,000 ambiguous melanocytic lesions, as I mentioned previously, and this split should match with the first slide with the people stick figures, in that most of the gene expression profile scores that resulted from the myPath melanoma test fall into this benign zone, with 65% of the results being benign, with 23% identified as malignant, which speaks to the issue at the core of the unmet clinical need, is that the majority of these ambiguous lesions are in fact benign lesions that don't benefit from specific surgical interventions, and the myPath melanoma assay can identify those that have that benign gene expression profile, distinguish those that have the malignant gene expression profile. So what is the clinical utility information to date for the myPath melanoma? There's been utility described for both dermatopathologists interpreting specimens and also for dermatologists that I'll run through here. So here from the study from UT Southwestern, on the left-hand side of the figure, the study focuses on a set of lesions where about 80.3% of the cases had an intermediate or indeterminate diagnosis histopathologically. So these were ambiguous cases that in practice without gene expression profiling would fall into that orange box where the malignant potential is uncertain. However, after the myPath melanoma test was used in these cases, there was a 69.3% reduction in that intermediate score. It was reduced down to 11%. And those intermediate cases filled up the other columns of benign lesions and malignant lesions based on their gene expression profile score, essentially shrinking the zone of ambiguous melanocytic lesions and confidently binning them as either malignant or benign in DermPath sign-out. This information is impactful when dermatologists receive information about their gene expression profile for the cases that they've submitted for dermatopathology review. So in this study performed at multiple centers, including the Cleveland Clinic, cases that received an intermediate diagnosis that had that ambiguous, uncertain malignant potential were routed overwhelmingly towards re-excision. Again, in common practice, ambiguous melanocytic lesions are treated to the worst case scenario in the differential diagnosis. So 93% of these cases were re-excised or recommended for re-excision by dermatology reviewers. However, when these same cases that had an intermediate or indeterminate histopathology obtained a benign gene expression profile score, there was a marked reduction in the re-excision rate for these cases. So dermatologists, upon receipt of benign gene expression profiling, can alter their management to avoid unnecessary re-excisions. There was a 80% reduction in the number of excisions performed based on their pretest recommendations, again, for the same clinical lesions. The only change is the receipt of a benign gene expression profile score. A more recent, smaller, single-center study from the St. Joseph Dermatology looks at a small group of lesions with about a 38.5-month follow-up that demonstrated that the effect that was seen in the previous two studies. So a group of lesions that received ambiguous diagnoses where the distinction between benign and malignant melanoma could not be made. When they received a benign gene expression profiling result, there was an 88% reduction in the number of re-excisions that were performed in this cohort, and there were no adverse events that were observed in patients who forewent re-excision in this single-center study. So what that really suggests is that clinicians are able to interpret the information provided by the gene expression profile test, change their management decisions around benign gene expression profile scores, and patients did not experience adverse outcomes as a result of those interventions. And this is laid out nicely here, just looking at these three slides, so that the clinical utility is well described for dermatopathologists rendering diagnoses, dermatologists receiving diagnoses that are informed by this additional diagnostic clarity, and that when in practice, the gene expression profile is integrated into patient management plans, patients who can safely forego re-excisions for gene expression profile benign cases that have an ambiguous histopathology. So the impact of the gene expression profile tests to address the unmet clinical need has been called out in guidelines. The NCCN guidelines from version 221 include gene expression profiling as one of the modalities that can be used by dermatopathologists to obtain diagnostic clarity in lesions where a distinction between a benign nevus and malignant melanoma cannot be made with confidence. And it's listed here among other ancillary diagnostic tests that can be used by dermatopathologists when it's incorporated in the context of the histopathology, other laboratory information, and of course the patient characteristics. And very recently here, from the second iteration of the dermatopathology appropriate use criteria, a committee formed by the American Society of Dermatopathology was just published in the Journal of Cutaneous Pathology. There's been a shift at recognizing the increasing strength of evidence around gene expression profiling to address this unmet clinical need. And there were multiple scenarios, three of which are in the adult population, that are now listed as majority usually appropriate in the dermatopathology AUC. And these describe some of the specific scenarios where you have a dermatopathologist confronting a lesion where the distinction between a definitive diagnosis of melanoma or a definitive diagnosis of a benign nevus can't be made with confidence. And so these are the moments where the dermatopathology community is identifying where the majority are usually appropriate for gene expression profiling in this test, when it will add diagnostic clarity to inform patient management decisions. So the unmet clinical need for these difficult to diagnose or ambiguous melanocytic lesions is actually not unique to dermatology, and there are other disease states that have similar intermediate histopathology criteria that lead to potential for overtreatment. And the best area to call a comparison would be in the field of thyroid pathology and the Bethesda criteria. So for both of these disease states, for thyroid nodules and suspicious pigmented lesions, there are multiple clinical diagnostic procedures that are performed every year to evaluate these. Fine needle aspirations in the case of thyroid, and diagnostic skin biopsies for pigmented lesions. And there's a significant subset in both disease states of this intermediate zone of histopathology, where clinicians who are interpreting these pathologic specimens run up against the limits of what's knowable using the tools that they have routinely available, immunohistochemistry, light microscopy. And the majority of patients who actually get these intermediate results are treated to the worst case scenario in the differential, and this leads to substantial overtreatment in both disease states. Of note, in both of these cases, these surgeries may not be providing any additional benefit to patients who fundamentally have benign thyroid nodules or benign pigmented lesions. And so the unmet clinical need for both of these instances is that gene expression profiling can add diagnostic clarity for these intermediate cases, and this information can inform treatment plans in both pathways to lead to avoidance of unnecessary procedures and providing a high level of care that's personalized to the pathology that a patient actually has for both disease states. Specifically for myPath, we believe that it can significantly reduce unnecessary procedures that are currently being performed on melanocytic neoplasms that do not benefit from additional surgeries. So shifting gears here from a diagnostic ancillary test of myPath melanoma designed to increase diagnostic clarity and confidence from dermatopathologists signing out cases and then dermatologists receiving information that leads to clearer management pathways for patients with ambiguous melanocytic lesions, onto the prognostic side of the DecisionDx melanoma assay that is only appropriate for patients who have a confirmed diagnosis of invasive cutaneous melanoma to inform several management decisions that fall subsequent to the diagnosis of invasive melanoma. So that puts us here a little bit towards the right on our patient journey after that diagnosis of a stage 1 through 3 melanoma has been made definitively by histopathology review. At this moment, the dermatologist who's treating the patient is confronted with a range of management decisions that follow the diagnosis of invasive melanoma. All patients with melanoma will be offered a definitive wide local excision, as is appropriate or as is possible based on the specific situation. But the decisions that are being weighed are, does my patient need a sentinel lymph node biopsy? Will they benefit from that additional staging procedure? Or can they safely forego that procedure? And then additionally, do I need a multidisciplinary care team? Are referrals needed for the management of this patient? What type of follow-up should my patient have in my clinic? And does that need to include surveillance imaging, for example? And so the DecisionDx melanoma is designed to improve the accuracy of risk stratification to inform these important management decisions for patients diagnosed with invasive cutaneous melanoma. Why is this important? Well, for invasive cutaneous melanoma, we have AJCC staging that does provide risk stratification for patients based on the pathologic criteria of their melanoma. Currently, this is based in AJCC version 8 on 2 characteristics based on the tumor stage, the breast load depth, and the ulceration. Those are the 2 features that go into the tumor stage. And then additionally, sentinel lymph node biopsy status completes the AJCC staging for patients. But this actually leaves much to be desired, as a staging-only approach can actually miss patients who have aggressive tumor biology who will go on to experience poor outcomes. And if you look at patients who are diagnosed initially as having stage 1 through 3 melanoma, the greatest number of deaths from melanoma actually occur within the stage 1 and 2 patient populations. Patients who are diagnosed with early stage melanoma at the time of their initial diagnosis actually experience about 60% of the deaths in the group of patients with stage 1 through 3 melanoma. And so what this means is that there are high-risk tumors that are misidentified as being low stage at the time of initial diagnosis, and this speaks to the potential for improved prognostic accuracy at the time of diagnosis that can inform risk-aligned management decisions to improve patient outcomes. There's significant evidence that demonstrates that early diagnosis, or early identification rather, of asymptomatic metastases leads to improved survival than when those metastases are identified clinically or symptomatically. And essentially, our current staging-only approach can lead to undertreatment and overtreatment based on a lack of prognostic accuracy around how dangerous a melanoma may be for a particular patient. So The current challenge that we are focusing on here and that the following slides will really address is this need that follows the diagnosis of invasive cutaneous melanoma to identify the correct patients that will benefit from a sentinel lymph node biopsy procedure, which is a staging procedure offered to patients with a subset of cutaneous melanomas. But in the current workflow that we have today, the majority of patients who actually obtain a sentinel lymph node biopsy will get a negative sentinel lymph node result and won't gain prognostic information from that staging procedure. There's no survival benefit directly from the sentinel lymph node biopsy procedure itself, as borne out in the MSLT1 study. The procedure itself has a false negative rate that is potentially significant, and it exposes patients to unnecessary anesthesia risks and surgical complications if it's offered to patients who were not likely to benefit from the staging procedure. NCCN guidelines also suggest that a patient's individual risk of recurrence should drive a range of management decisions, and that includes an individual's pretest risk of sentinel lymph node positivity to inform whether or not a patient should obtain a sentinel lymph node biopsy itself. So currently, to go into a little bit more detail, the tumor stage, again, that combination of breast low thickness and ulceration, are the two pathologic factors that dictate whether or not a patient is currently routed to obtain a sentinel lymph node biopsy. So patients with T1A high-risk tumors or T1B tumors are thought to have a 5 to 10% risk of a sentinel lymph node that's positive, and these patients are offered discussion and consideration of sentinel lymph node biopsy. Patients with T2A to T4 tumors are thought to have a greater than 10% risk of sentinel lymph node biopsy positivity, and they're routed to discuss and offer a sentinel lymph node biopsy by guidelines. However, patients who have a T1A tumor all of them are thought to have a less than 5% risk of sentinel lymph node biopsy, and they're sent to forego sentinel lymph node biopsy under current approaches. But again, highlighting that this stratification approach of who is discussing and considering or discussing and offering a sentinel lymph node biopsy leads to a sentinel lymph node biopsy staging approach where 88% of the patients who obtain a sentinel lymph node biopsy today actually have a negative sentinel lymph node and don't get additional prognostic benefit or information from the sentinel lymph node biopsy staging procedure itself. And there's been discussion in academic literature about the role for sentinel lymph node biopsy to inform melanoma staging. And it essentially, this article from Bigby et al., a surgical oncologist from Harvard, really discusses the limitations of the sentinel lymph node biopsy procedure itself, highlighting that it does not provide a survival benefit for patients who obtain the sentinel lymph node biopsy itself, and fundamentally deserves reappraisal within the Dermatology and Surgical Oncology Academy. The specific benefit of the sentinel lymph node biopsy itself on improving the accuracy of staging hasn't been well studied, is the comment here, and essentially identifying that we could do better in the medical community to route patients appropriately to obtain a sentinel lymph node biopsy or not, using additional information to really identify the group of patients who are most likely to benefit from this additional staging procedure and those who can safely forego the procedure. So this really is the background for the unmet clinical need that DecisionDx Melanoma can help to address, identifying a group of patients who are likely to benefit from sentinel lymph node biopsy and those who can safely forego this procedure. DecisionDx Melanoma was launched in 2013. Again, it has a CPT code that's proprietary and effective in January 2021. Over 75,000 patients have received testing with the DecisionDx Melanoma test, with over 8,000 clinicians placing those orders. It's covered by Medicare for 2 indications. We'll focus here on the sentinel lymph node biopsy information as outlined. And there's a large set of data in multiple publications, over 30 publications with over 5,000 patients under study in those publications that include retrospective validation studies, prospective studies, multi-center studies, meta-analyses, and again, there are multiple NCCN and NCI study centers across the country that are using this test to inform the management decisions for their patients with invasive cutaneous melanoma. So before going into some of the details around sentinel lymph node biopsy guidance, a bit of background on DecisionDx Melanoma. So again, the test was developed to provide independent prognostic information to assess the risk of recurrence that's independent, again, from traditional clinical pathologic factors that are available for patients diagnosed with invasive cutaneous melanoma. It's an assay that is based, again, on the formalin-fixed, paraffin-embedded specimen that's diagnostic of a patient's invasive melanoma, and it's an RT-PCR-based test that applies a proprietary gene expression profile algorithm to produce one of four outputs or scores from the gene expression profile test itself. Those scores are Class 1A, that's the lowest risk of recurrence or metastasis within 5 years, Class 1B or Class 2A, which speak to an intermediate risk, which is an increased risk of metastasis or recurrence over 5 years, and then Class 2B, that highest risk of recurrence or metastasis in 5 years. The breakdown of clinical reports is shown here on the right, where the majority of tested lesions, about 74% of these cases, get a Class 1A result, that lowest risk score, with 11% receiving the Class 2B highest risk score, just showing the breakdown of the class distribution of the DecisionDx melanoma tested patients. So in the next section, I'll be focusing on the value of gene expression profile testing with DecisionDx melanoma to inform sentinel lymph node biopsy guidance. So again, just to call back, this is the rubric under which patients are currently routed away or towards sentinel lymph node biopsy based just on that T stage, the combination of Breslow thickness and ulceration. And so the procedure is focused on taking patients with T1A melanomas and having them avoid sentinel lymph node biopsy, and T1B and above, or T1A high risk and above, routed at least to have that conversation. Castle Biosciences has focused multiple studies on demonstrating clinical utility to focus on these intermediate thickness tumors, thin and intermediate thickness tumors of T1A high risk to T2 patients who have a predicted 5 to 10% possibility before their test with DecisionDx melanoma, or over 10% of predicted pretest risk of sentinel lymph node biopsy, and identifying, is it possible to find a group of patients who have a less than 5% risk of sentinel lymph node biopsy within this group of patients of T1 to T2 melanomas who can safely forego the procedure based on the fact that they actually would have a less than 5% risk of having a positive sentinel lymph node. And so I'll go through the two main studies that have identified the ability for DecisionDx melanoma to accomplish just this. In 2019, from Dr. Vedo et al., from a multi-center study that included Northwestern and OHSU, it really focused on a group of patients with T1 to T2 melanomas to see if we could identify a group of patients who can safely forego the procedure. And the conclusions of the analysis identified that patients over the age of 55 with T1 to T2 melanomas who obtained a Class 1A result, the lowest risk result from the DecisionDx melanoma assay, had a less than 5% risk of sentinel lymph node biopsy positivity, and who could therefore safely forego the sentinel lymph node biopsy procedure. This would result in a 66% reduction in sentinel lymph node biopsy procedures, again, because we're starting from a group of patients that are currently routed to receive sentinel lymph node biopsy based on their T stage. And so it demonstrates that the DecisionDx melanoma test, in combination with these clinical and pathologic factors, can in fact identify a group of patients who have a low risk of a positive sentinel lymph node biopsy. So this is a model that's based on this Vedo paper describing what would happen if you take patients who are eligible currently and are receiving sentinel lymph node biopsies and use the DecisionDx melanoma test result to route them appropriately based on their risk of having a positive sentinel lymph node. So starting on the left, this is from the Vedo analysis, patients who were eligible and considered for sentinel lymph node biopsy over the age of 55. Not 100% of those patients actually obtained a sentinel lymph node biopsy. There's an element of self-triage that happens in current practice where patients, for a multitude of reasons, who are eligible don't always get a sentinel lymph node biopsy. They're routing themselves to avoid or to obtain this procedure in conversation with their clinician. So 78% of the eligible patients in this group obtained a sentinel lymph node biopsy. And in that breakdown of patients, there were fully 60% of those individuals who had a Class 1A result. So based on those findings, those patients had a pretest risk of less than 5% for sentinel lymph node biopsy positivity and could have safely foregone that procedure. So if you bring back the subset of Class 1A patients and the 21% of patients who did not obtain a sentinel lymph node biopsy, and add the Class 1A patients who did obtain a sentinel lymph node biopsy, you can identify before the procedure itself that there were 64% of these patients aged 55 and older who could have safely avoided the sentinel lymph node biopsy procedure in this cohort based on their less than 5% pre-procedure risk of having a positive node. This would lead to significant reductions in unnecessary sentinel lymph node biopsies in this group. And in the subsequent slides, I'll show that it would not have untoward effects on patient outcomes. So these are three prospective studies that have been performed that contain information about sentinel lymph node biopsy status, in addition to survival information. These would be Keller 2019, Arnott 2021, and Shea 2021, seen here in this table. They have significant median follow-up times across these studies, and the sentinel lymph node biopsy does identify a significant group of patients who have excellent recurrence-free survival. So 88 to 91% recurrence-free survival among patients who had a negative sentinel lymph node biopsy. But as seen here in the lower column, patients who had a low-risk gene expression profile score also had excellent survival, ranging from 94 to 97% recurrence-free survival. And what this suggests is that patients who have that low-risk DecisionDx melanoma score actually have sustained excellent outcomes, and so that they can safely forego the sentinel lymph node biopsy procedure. More recently, Castle has obtained even more tested patients with known sentinel lymph node biopsy outcomes. And so the VETO cohort that again contained over 1,400 patients has now been combined with an additional novel cohort of over 1,600 patients in what is now called the I31GEP, the integrated test report for DecisionDx melanoma that I'll outline here now. So this is described in a manuscript recently published by Whitman et al. In JCO-PO earlier in 2021, describing this cohort of over 3,000 patients, where the VETO cohort is used as a training cohort, and this integrated report is validated in the independent 1,600 patient cohort here. What this approach is using is an integrated look at all of the clinical pathologic variables that are available to clinicians at the time of a melanoma diagnosis. All of those were painstakingly abstracted from the pathology reports, and the factors that added prognostic or information about the patient's risk of a positive sentinel lymph node were incorporated into a neural network-based algorithm to produce a precise risk score. And essentially, this I31GEP can improve personalized risk estimates for sentinel lymph node biopsy positivity by including the DecisionDx melanoma continuous score, breast low thickness, mitotic rate, ulceration, and age into a unified test result. This actually has applicability across the disease spectrum of T1 to T4 melanoma, where this I31GEP had excellent test performance. And fundamentally, it strengthens the clinical utility of the DecisionDx melanoma assay to identify a group of patients who are currently eligible and receiving a sentinel lymph node biopsy, but who actually have a less than 5% predicted risk of sentinel lymph node biopsy who can safely forego the procedure. In T1 to T4, there's a 98% negative predictive value of the less than 5% range. Focusing just on the T1B, a particularly impactful group of patients who are currently all routed to obtain a sentinel lymph node biopsy, the I31GEP in the study had a 97.8% negative predictive value for patients who obtain a less than 5% risk of a positive sentinel lymph node. And so this could lead to a 40% reduction in sentinel lymph node biopsies in patients who are currently being routed to receive the sentinel lymph node biopsy procedure itself. Importantly, the study also contained outcome data in a nested prospective cohort within the study, so that patients who obtained a less than 5% risk of a positive sentinel lymph node output of this integrated report actually have excellent long-term outcomes. Their outcomes are seen here in the Kaplan-Meier curve in blue, where patients who had a predicted less than 5% risk of sentinel lymph node biopsy positivity had a 96.8% 3-year recurrence-free survival and a 98.6% 3-year distant metastasis-free survival. So it identifies a group of patients who can not only forego the procedure based on the low likelihood that it will receive a positive result, but also because those patients will sustain excellent long-term outcomes, and so they are not harmed in any way by foregoing their sentinel lymph node biopsy procedure. So again, adding to the table that I presented earlier, the Whitman et al. Study now presents the I31GEP as another way to identify how DecisionDx melanoma can identify patients who will sustain excellent long-term outcomes, in addition to identifying patients who can safely forego the sentinel lymph node biopsy. And this speaks to the ability of the DecisionDx melanoma test to inform not only the sentinel lymph node biopsy decision, but also important decisions about cadence of follow-up, quality of follow-up, whether it includes surveillance imaging and referrals to additional providers, based on the ability to inform and improve the accuracy of risk stratification for outcomes of interest for patients. This integrated report is now included as part of the DecisionDx melanoma report. In addition to the class score, patients receive a precise, personalized likelihood of their sentinel lymph node biopsy positivity seen here on this draft report. And so in summary, just going through the evidence that supports the use of gene expression profiling testing to predict sentinel lymph node biopsy positivity in patients with T1 to T2 tumors that have that 5 to 10% predicted risk of sentinel lymph node biopsy positivity. First, on the far left, the sentinel lymph node biopsy procedure is prognostic only, essentially does not confer specific survival benefit as outlined in the MSLT1 study for intermediate thickness melanomas. And the majority of patients who undergo the procedure don't benefit from additional prognostic information because they receive a negative sentinel lymph node biopsy. And their current staging approaches misses a significant subset of patients who sustain poor outcomes as a result of their invasive cutaneous melanomas. And gene expression profiling can improve the accuracy of risk prediction to inform our clinical decision making. Current approaches use the T stage of a melanoma to identify patients who should discuss and consider or discuss and offer the procedure, and those who have a less than 5% predicted risk are actually routed currently to forego the procedure based on its low likelihood of benefit to those individuals. Multiple different approaches at Castle with the Veto et al. And Whitman et al. Manuscript have identified that DecisionDx melanoma can accurately identify groups of patients over 55 years and older with class 1A result, or patients with a less than 5% I31 GEP result, who can safely forego the sentinel lymph node biopsy procedure based on the low likelihood of positivity and the fact that they'll sustain favorable outcomes. And subsequently, there's a net health benefit to patients who can safely forego this procedure, as it reduces their exposure to unnecessary surgical risks that they are unlikely to benefit from because of the low likelihood of sentinel lymph node biopsy positivity that these patients actually have. And subsequent to that, they sustain excellent long-term outcomes because, again, their low-risk gene expression profile score also connotes, and in the published evidence, excellent long-term outcomes for relapse-free survival and distant metastasis-free survival. And so thank you for your attention, and we'll pause for questions at this time.
Thank you, Dr. Goldberg. If there are any questions, feel free to enter those into the chat. Okay, it looks like we have one. You mentioned utility of the test for cadence of follow-up, modality of follow-up with regards to relapse-free survival. Can you speak a bit more to how the test result can be used for follow-up for sentinel lymph node negative patients?
Yeah, it's a good question. So the focus of the presentation here today is really on sentinel lymph node biopsy guidance decisions. We spent a significant amount of time on the Veto paper and the Whitman paper talking about how patients with over 55 years and older with a class 1A result, or patients with a I31 GEP less than 5%, have that less than 5% predicted risk of sentinel lymph node biopsy positivity, and therefore, based on their risk of sentinel lymph node positivity, can safely forego that procedure. What follows there is that those patients who have that low risk score, I'm backtracking here to this slide on survival, are actually documented based on prospective data to have excellent long-term survival, right? So not only do these patients have a low likelihood of obtaining prognostic information from a sentinel lymph node biopsy, but the gene expression profile improves the accuracy of risk prediction about their long-term survival as well, about whether the patient is likely to experience disease relapse, whether that patient is likely to experience distant metastasis from their melanoma, and that low risk score for their risk of sentinel lymph node biopsy positivity also provides information about their likelihood of these recurrence and distant metastasis events. And so what this speaks to is that patients who are risky enough to be eligible and considered for a sentinel lymph node biopsy, who obtain testing with DecisionDx melanoma, can be subsequently risk stratified or have their risk stratification improved by the addition of gene expression profiling. Because again, most of the patients that are eligible for sentinel lymph node biopsy will actually have a negative node. And after that biopsy is obtained by surgical oncologists, there are often multiple visits with that surgical oncologist, a regular follow-up in that practice, in addition to the follow-up that takes place with their dermatology providers. And we've seen from multiple centers that surgical oncologists use the information in their patients eligible and assessed for sentinel lymph node biopsy to address those concerns. This is from, I think, highlighted in a paper by, I'm going to pronounce this incorrectly, Dr. Schutevoiter et al., that really talks about how the DecisionDx melanoma test can inform imaging decisions as well in a group of patients eligible for sentinel lymph node biopsy. And surgical oncologists are using this to adjust and titrate their follow-up, in addition to dermatologists who are adjusting their follow-up intervals based on the DecisionDx melanoma test results as well. So it's this ability to not only describe the risk of sentinel lymph node biopsy positivity, but also information about relapse and distant metastasis that allows the clinical utility for both sentinel lymph node biopsy guidance and those subsequent decisions that follow diagnosis with melanoma.
Thanks, Dr. Goldberg. One more question that you kind of led into here. Nice transition. Can you speak to any potential for therapy guidance as we have with GEP for breast cancer?
Yeah, that's another good question. It's one of the things that's unique about the breast cancer and gene expression profiling is that the data that was available at the time of development of those assays was substantively different than the information that's available for cutaneous melanoma. In breast cancer, there were repositories of tissue across the disease spectrum of breast cancer for women who were treated with systemic therapy, chemotherapy for their breast cancer. So early stage patients with ER/PR positive tumors, as well as late stage patients who were all treated with chemotherapy. And so the tests, the gene expression profile tests for breast cancer have a predictive for therapy guidance component because they're a subset of patients who were tested in the original development and validation included patients who were treated across the disease spectrum of breast cancer. In melanoma, immunotherapy and other systemic therapies have been fundamentally limited to late stage only patients. So only patients who have seen systemic therapy in melanoma include stage 3 and stage 4 patients. And now just recently in December of 21, now stage 2B and 2C patients are on label for systemic immunotherapy with pembrolizumab. However, at the time of development and even today, early stage patients, stage 1 and 2 patients overwhelmingly are not treated with systemic therapies. And so as a result, predictive gene expression profile testing is not possible because there are no patients with stage 1 or 2 disease who have been treated with systemic therapies who have long-term outcomes. So the DecisionDx melanoma test is not predictive in that sense. It is a prognostic assay, and the core of the validation data speaks to the ability of the test to provide statistically independent prognostic information than the information that's provided by the AJCC staging criteria alone, and that it improves the accuracy of risk prediction for patients with melanoma to inform risk-aligned management decisions. We do not have the ability to inform specific therapeutic decisions because there are not those tested patients. What the test does provide is a more accurate picture of a patient's risk for relapse, distant metastasis, and death from their melanoma. And then clinicians use that information in our clinical utility studies, highlighting how that information is taken up to inform subsequent management decisions that are risk aligned with that more complete personalized picture of a patient's risk for these poor outcomes. That was a long answer to a short question. My apologies there.
Thank you. Are there any other questions? Okay, well, it appears that unless you have anything you'd like to add, Dr. Goldberg, looks like there are no further questions.
Thanks everyone to your attention this hour and for joining us here in this conversation. And thanks to Julia for hosting. Appreciate it.
Thank you very much.